All right. Hello, everyone. Thank you so much for coming to the session. My name's G. If you've not been to one of my sessions before, I'm the Sexual Health and Infectious Diseases lead for Mind the Bleep for this year. And we're just going to talk a little bit about sexual dysfunction today. So it won't be a very long session. I'm estimating sort of half an hour to 40 minutes. So hopefully nice and short and sweet, and you'll learn something. I've got Bumini kindly moderating for me today. So if you've got any questions in the chat, I won't be able to see it while I'm presenting, so she will be sort of fielding those questions to me. I'm assuming you can all hear me okay. If not, please pop a message in the chat and we'll try and sort that. But yeah, if nobody's got any questions before we get going, I will get started. So our learning outcomes for today are to understand what dyspareunia is and the ways we can classify it, to describe and differentiate causes of dyspareunia and erectile dysfunction, and to formulate plans for investigation and management of dyspareunia and erectile dysfunction using a holistic approach. So, what is dyspareunia? So it's just pain during sex. So it can be classified into superficial and deep, and primary and secondary. So superficial is felt more at the entrance, it's kind of self-explanatory, and then deep is felt deeper inside and sometimes in the abdomen as well. Primary means the patient has never had a sexual experience without the dyspareunia, whereas secondary, it will be something new, so they'll classically say, well, everything was fine up until XYZ happened, or until 6 months ago, and then we have to kind of do our detective work to try and find out what could have caused that. Okay, so there are a multitude of different causes of dyspareunia, so I've kind of tried to put them in a little mind map sort of thing here. Sorry if any of you can hear that dog barking. I'm not sure whose dog that is. So we can kind of go top to bottom, and kind of one of the things I wanted to touch on with dyspareunia and with erectile dysfunction, actually we'll talk about it later, is that it doesn't just involve genital related causes. So when we say like treating with a holistic approach, it's really important to think about all different aspects of a patient's life and how they can influence all different parts of their life, not just their sexual experiences. So if we start at the top, UTI, so that can cause burning, stinging, it can cause skin irritations, that can cause usually more superficial dyspareunia, but also if you had a UTI that progressed to sort of pyelonephritis, you could get more abdominal pain with that. STIs and PID, so if you haven't already, if you're looking to get some more information on STIs for finals, I've got a session on that. It's up on Medal and on YouTube. So that kind of goes into more details about recognising, investigating and treating each STI, so I won't talk about them in much detail here, but lots of different STIs can cause both superficial and deep dyspareunia. And then PID, so pelvic inflammatory disease, can be caused by STIs or by infections sort of acquired from other sources, and that usually causes a deep dyspareunia. I believe PID is covered by our lovely gynecology team, so if you're looking for more information on that, I would have a look into their sessions. Endometriosis, so this is something that's been in the media a lot recently, which is great. We're getting sort of more public knowledge of it. It's essentially where you get deposits of uterine tissue outside the uterus, and then of course when you're going through menstruation, those deposits can bleed, they can cause a lot of pain. Classically, patients will get quite heavy periods with a lot of pain, and it can be quite debilitating for people as well. And malignancy, always something we need to have in the back of our minds with any patient really presenting with anything. Could whatever symptoms they're having be caused by a malignancy? So things to consider here are cervical cancer, uterine cancer, ovarian cancer, and obviously that depends on when you get more information from the patient, maybe asking them things about systemic symptoms like weight loss, night sweats, poor appetite, increased fatigue. Always really good to ask with any patient, regardless of what symptoms they're presenting with. So candidiasis is our next one. So thrush, that can cause, again, skin irritation and generalized discomfort. Vaginal dryness, so this can have a multitude of different causes. One of the common ones that you'll see, especially if you're in GP and you get a lot of gynae patients coming into you there, is menopausal women or menopausal people with vaginas coming in. Basically, when you go through menopause, your estrogen decreases. That can cause less sort of natural secretion and lubrication of the vagina, so that can cause dryness. And then obviously if you're sexually active and you're not lubricated enough, that can cause a lot of discomfort and pain for people. Another cause is if patients aren't sort of using lubricant during sex, or they're not doing enough foreplay and they're sort of just going straight into penetrative sex, that can just not be realistic for some people, and it can cause a lot of discomfort. Structural abnormality, so it is what it says on the tin. Do they have some sort of a difference in their anatomy that is causing pain or discomfort during sex? Vaginismus, so this is a presentation where patients will have involuntary muscle contraction. That means it's very, very painful for them to have anything inserted into the vagina. So often this can stem from a past trauma or a difficult experience earlier in their life. It can be treated really quite well with psychological therapy. You can get amazing psychosexual therapists, and they do really great work with a lot of patients with vaginismus, and they can use things like dilators as well, just to kind of get the body used to having something inserted, and it kind of just trains their body not to have these involuntary contractions. And then irritation and dermatitis, so lots of patients think it's necessary to use scented soap inside, which is just not what we would recommend. It can cause a lot of irritation, mess up your pH balance, and that can in turn cause dyspareunia. And then more the mental health side of things, so anxiety or tension nerves or a past history of sexual trauma. Again, it can cause patients a lot of discomfort, even if they're maybe not aware of what's causing them to feel anxious, or their body might have sort of that fight or flight response, maybe because they've had a past traumatic experience that either they haven't addressed, or it's one of those things that we see a lot of patients who may not even know what that trigger was for that reaction until they kind of explore further backwards in their lives. And some people present and they go, well, this happened to me, and obviously that's very, very traumatic for them, and it can cause them problems during sex. Okay, so those were a few of the examples that I thought of. So when we're trying to work out the cause of dyspareunia, we need to kind of be like detectives. So some really helpful questions that we can ask are listed below. So these are sort of, some of them are quite obvious, or I don't know what the word I'm trying to think of is, but they're questions that you might ask patients presenting with any kind of pain, looking at sort of like your Socrates of pain. So onset of symptoms, like we said before, primary versus secondary dyspareunia. So if they've always had dyspareunia, it might indicate an anatomical difference or a psychosexual condition potentially. So have they had any childhood sexual trauma? Obviously, when you're asking patients these questions, they're very, very personal. So ideally, you want to know the patient. It's not always possible. Sometimes it might be the first time you're seeing them, but if you can try and build up a bit of that rapport, make sure that they're comfortable and happy to discuss anything. And I think it's always useful to just go over confidentiality, that you're not going to say anything that they say to you outside of the room. Only caveat to that is if they say something that indicates that they or someone else might be in danger, in which case we are legally obligated to. But for the majority of patients, what they discuss with you will never leave that room unless they want to talk about it with someone else. Location of symptoms. So like we said before, superficial versus deep dyspareunia, that can kind of help you work out, okay, so if I've got superficial dyspareunia, likely the cause of that is going to be obviously more superficial. And if it's deep dyspareunia, I'm looking at maybe a pelvic pathology, something in the abdomen. It helps you kind of narrow down what investigations might be useful. Do they have any associated symptoms? So itching, discharge, dysmenorrhea, so painful periods, or dyschezia, those are two really good indications that the patient might have endometriosis. It's also really good if you're thinking of something like endometriosis to get a full menstrual history from them. So when did they start their periods? Have they always been heavy? Have they always had really bad pain? And again, that can really kind of help guide you towards or away something like endometriosis. And the quality of the pain, so is it sharp? Is it achy? Is it dull? As they said there, that sensation of tearing, it might be related to atrophy. So that's kind of what I was talking about with menopause. They might describe it as a burning or a tearing, like they say here. Usually the patients that I've seen in the past, I think, would describe it as like a burning or like a stinging or like something's on fire. Alleviating factors, so pain that improves with a contraceptive pill or a coil, for example, that's quite suggestive of something like endometriosis, because essentially what that does is it regulates your cycle, and it stops your, like, so if you're on the progesterone only pill, or you're tricycling your contraceptive, your combined pills, you're not going to be having periods. And if that is what's helping them, it might be suggestive that they have something like endometriosis, which is to do with menstrual cycles. Estrogen therapy, so you can do that topically if they're menopausal and they're finding that they're quite dry down below, or you can just use a topical lubricant. That's a really nice, easy fix for a lot of people, and something they can just buy over the counter. Then a medical history. So like we said before, we want to be keeping things like malignancies in the back of our mind for any patient. So have they had cancer before? If they've had, for example, if they've had ovarian cancer before and their symptoms were weight loss, bloating and dyspareunia, are they having the same again? Because that might be something that suggests to us, or have they had a reoccurrence of their cancer? Do we need to put them on a 2-week wait? And again, like this says here, previous chemo or radiotherapy can also cause atrophy, so it's really helpful to know. And then commonly things like contraceptives and antidepressants and other medications can also reduce your natural lubrication, so very, very good to know a full medication history. Obstetric history, so have they had any episiotomies? Have they had C-sections before? Have they had a traumatic birth that might have given them sort of psychological difficulties with having sex afterwards? And then just this bottom point, so symptoms consistent with superficial dyspareunia related to levator-anal spasm and vaginismus will be found in association with many of the other conditions. So basically all that's saying is, if they're sort of having symptoms that sound like vaginismus, where they're having this sort of involuntary tensing, you can have those symptoms with a lot of these different things, because if you've had one bad experience where sex has been really, really painful for you, and then you're going to try again and do it again, whether it's deliberate or not, your body's going to be anticipating that you're going to be put in pain. And again, that can cause this cycle of difficulty for patients where they're struggling, even if the original problem that caused them dyspareunia has been solved or been treated, they might still have remaining sort of trauma from that, which is something that can change the way we manage it. We might need to add in more psychological support for them. Okay, so some of the investigations we might want to do for patients with dyspareunia. So obviously thorough history for everybody. Always keep safeguarding in the back of your mind, especially when you've got patients presenting with sexual health or gynecology problems. Like I said, you want to build a good rapport with your patient if possible, and be really, really sensitive throughout, because some of these topics are very difficult for patients to discuss or very emotive. A speculum and a bimanual examination, good to do with basically every gynae presenting complaint that you get, because it can give you some really good information. You can have a look externally. So for some patients, say if it's menopause related dryness and reduced estrogen, you might be able to see that the skin around is thin, raw, dry, and that can kind of give you some really good information first off. And then with your bimanual, say if you've got tenderness on moving the cervix, that could be suggestive that they've got PID or an STI. or you might be able to see some discharge. You might be able to swab that and stick it under the microscope. So loads and loads of information that we can get just from a simple speculum and bimanual. The one thing to note, though, with sort of speculum and bimanual examinations, if you've got a patient with any past sexual trauma or with symptoms suggestive of vaginismus, it might be very, very difficult for them to have this kind of an examination. So off the top of my head, things that can help, obviously, talking through everything that you're going to do beforehand and talking through as you're doing it. They might want another healthcare professional in there just to talk to them while it's happening. Some patients find it very helpful if they're the one that puts the speculum in, and then you can just sort of adjust it, because it gives them that control and that empowerment that they're the one sort of introducing that into their body. Speculums and bimanuals aren't going to be possible for every single patient, especially if you're in a GP surgery where you've got a bed up against a wall and it's difficult to get them in a comfortable position. So if necessary, refer on to gynae. There's always a way around these things, and we just need to support our patients and make sure they're as comfortable as they can be. Full STI screen. So ideally do this for every patient, but obviously some patients who've been in monogamous long-term relationships, it might not be applicable for them and they might not prefer to have one. That's absolutely fine. Gram stain microscopy. So like I said, while we're doing our speculum examination, even if you can't see obvious green or yellow or different looking discharge or with a scent, it's always good to just take some samples, pop them under the microscope, because patients don't always present the way that we see them in textbooks, and it can just be really helpful to go, right, so I definitely know from my microscopy and my culture that it's not gonorrhea or chlamydia or whatever else. Pelvic ultrasound, so useful if you're wondering about things like fibroids. If you're in a well-equipped sexual health centre or community gynecology, you can often just do a pelvic ultrasound with the patient in that appointment if that's something that they're comfortable with, which again, really great point of care test. Doesn't take very long. As long as you or one of your colleagues is trained, it can give you really, really useful information very quickly. And then for things like endometriosis, diagnostic laparoscopy, that's our gold standard. So obviously very invasive, it's an operation. Patients will have to be consented appropriately by a hospital gynecology team for that. But if it's something that you're really thinking about seriously, that it could be something like endometriosis, this can give patients a lot of answers and mean that they can have, during the diagnostic lap, a lot of the time they'll have endometriosis removed, and that can help with symptoms. Urine dip and an MCNS, again, very easy, very quick, can be done in any healthcare setting, and it can give you a really easy fix. If you find out that they've got a raging UTI, you can treat them with antibiotics, and that can help a lot of people. If you see any suspicious lesions, biopsy. If patients are having non-specific gynae symptoms plus weight loss / night sweats, anything like that, you can 2-week wait them. And I would really encourage that. It would be much better, in my opinion, if we 2-week waited too many people rather than not 2-week waiting enough people and we miss something really serious. So our management of dyspareunia. So like I said before, some causes are really easily reversible. So a UTI, some STIs like chlamydia, gonorrhea, course of antibiotics. For gonorrhea, you might need a test of cure and then that's sorted. And if that is the fix to the patient's symptoms, that's great. For atrophy, we can use things like estrogen cream or lubricants. For patients with vaginismus, like I said before, we have some amazing psychosexual therapists. They do amazing work with their patients, and they can use tools like dilators, which patients can use in their own time, in the comfort of their own home, and work on their symptoms at home as well as when they come to their appointments. For endometriosis, they'll need a gynae referral. They may benefit from some hormonal contraception just to regulate their cycle, a therapeutic lap and excision, so that's the surgery that we mentioned before, and additional analgesia just to help them during their periods. General advice, so like I said, avoid using scented soap or body wash or deodorant around the vulva. Douching, again, we would advise patients to avoid that, and if they are allergic to latex, as obvious as it sounds, don't use anything with latex in. So I think, to be honest, I think most of the places I've worked, all the gloves that we use are latex free anyway, but if you've got a patient with a latex allergy, they'll obviously need latex free condoms or dental dams. And good communication with partners is incredibly important. So I find that patients often get better outcomes if their partner or partners are aware of what's going on, supportive. I think it helps patients feel safe if they've got a partner or partners that understand that they may need to take things slower or do things slightly differently, or they may need to stop, which I would hope that anyone in a sexual relationship treats their partner like that. But it's especially important for patients who already have pain or other problems during sex. Okay, so we've kind of covered the basics of dyspareunia, so I'm going to move on to erectile dysfunction now. So first off, what is it? So this is like a wordy definition, but persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. So essentially, erectile dysfunction, it's a symptom. It's not a disease in itself, as much as sort of media might portray it like that. So it's just a sign that something else is going on and it needs to be investigated. It's very, very common, more likely the older you get. And there are 3 groups of causes. So we have our organic causes, our psychogenic causes, and our drug causes. So just so that we understand a little bit more about the physiology of an erection. So essentially it's all to do with blood flow. When people with penises get an erection, their smooth muscle relaxes, blood flows, and then it gets cut off at the top. So essentially it stays in the penis. That's what causes it to get erect and firm. So if we remember that when we're looking at our causes, there's lots on this slide, I'm aware of that, but kind of a lot of it's related. So if we start at the top, our vascular causes, so basically I would argue many males over the age of sort of 50 these days would have quite a few of these, which kind of explains in part why erectile dysfunction is so common. So hypertension, hyperlipidemia, peripheral arterial disease, diabetes, smoking, and obesity. And we move on to our neuronal causes, so MS, Parkinson's, stroke, spinal cord or central nervous system disease. Neurogenic, so diabetes again, CKD or chronic liver disease, and then pelvic or urological surgery. And then anatomical, so Peyronie's disease, which is what the little diagram above there is. So essentially it's growth of fibrous plaque that causes the tissues to bend, and patients end up with a significant bend in the penis, which causes a lot of problems. And then prostate cancer as well. And then our endocrine causes, diabetes again features hypogonadism and hyperprolactinemia. So I don't think you need to remember all of these. Basically, the point of this slide is to reiterate that erectile dysfunction is not just caused by 1 or 2 things. Again, it's about that holistic look for each patient, so full medical history, all of their medications, and really have a look at all aspects of their life. Okay, so if we have a little bit of a look in drug-related and psychogenic causes of erectile dysfunction. So drug-related, this isn't an exhaustive list, but some of the things to keep in your mind are antihypertensives, diuretics, antidepressants, any hormonal treatments, and recreational drugs. And then our psychogenic side of things, which is again very, very common with a lot of patients, especially younger patients. I think there's a lot of stress and pressure that people put on themselves to quote unquote perform, and that causes a lot of people quite significant distress. Other things can be things like relationship problems, depression, anxiety, and just general stress in life. And then this bit at the bottom, I thought was quite like a good little tip. So an organic cause is suggested by a gradual onset of symptoms, lack of tumescence, and low to normal libido, whereas a psychogenic cause is suggested by a sudden onset of symptoms, low libido, and good quality spontaneous or self-stimulated erections. So essentially, for a lot of patients, like I said, it's this pressure to perform. So if that they're not having problems, perhaps when they're alone, when they're with a partner, they're having issues. It's not, a definite this way or that way, but it's just something to keep in the back of your mind that might help you narrow down what's causing all of their symptoms. Okay, so taking a history, pretty broad when you're looking at erectile dysfunction, just because, like we've discussed, the amount of different causes that there are. So, your history will have to be a mixture of sexual health, urology, and cardiovascular, and also a bit of mental health in there as well if you're thinking it might be a more psychogenic cause. So basically, we want to get some more information. When was the onset? What's the timing? Clarify if it's problems initiating or maintaining an erection, or it's both of them. If they've had any current or past relationship problems, problems with arousal, mental health problems, and also how it's affecting their daily life. Because I don't know where everyone else is going to uni. I went to Newcastle, and one of the things that they really liked us doing there was what they called ICE, so ideas, concerns, and expectations. And I think it's really, really important, not just with psychosexual problems, but just with anything, what actually matters most to the patient and what part of this is affecting their daily life the most. And I think when you get the patient's perspective on what's worrying them, what matters the most to them, it can really help you narrow down your investigations and your treatment as well to make sure that you're addressing what matters the most to them. Have they tried anything to help before? Did anything help in the past? Past medical history, so cardiovascular risk factors, so like we said before on our flowchart, are smoking, obesity, high cholesterol, diabetes, a family history of cardiovascular disease, any previous prostate cancer, have they had any previous pelvic or retroperitoneal surgery or coronary revascularization, have they got any lower urinary tract symptoms, because again, similar to our dyspareunia, it could be a very simple cause that they've got a raging UTI, it's causing them pain and problems. And then rarer cause, but good to screen for in anyone with presenting with erectile dysfunction, signs and symptoms of low testosterone. So have they got a low sex drive, low muscle mass, fatigue? Have they struggled with infertility? And then any known anatomical differences, so like we talked about before, Peyronie's disease, or have they got any testicular abnormalities? Okay, so our investigations. So always just good to get some basic observations like a blood pressure, a heart rate, a waist circumference, a weight, a BMI, blood tests. So the main ones for our cardiovascular risks are an HbA1c and a lipid profile, because you could have, say, a 45-year-old man presenting with erectile dysfunction who says he's completely fit and well, but actually he's not been to a GP in 10 years, and turns out he's got type 2 diabetes, hypercholesterolemia, and high blood pressure. So always good just to do all of these tests just to rule out those causes. Depending on what they present with, might be worth doing a serum fasting total testosterone if you're thinking that they might have a sort of low testosterone, a PSA if you're worried that they might have prostate cancer, thyroid function tests, liver function tests. Using these can all be very useful. A good one to do, especially if someone has a lot of cardiovascular risk factors, is a Q-risk score. So not just for people with erectile dysfunction, this is anyone who has any sort of cardiovascular risk. It's a really good, really easy one to do. You can just Google it and fill it in, and it shows them their 10-year cardiovascular risk. It can be very, very helpful, because if this is particularly high, I might suggest to you that the cause of their erectile dysfunction is more likely to be cardiac in nature. And even if that's not the cause, if they have a high Q-risk score, they need to be seen probably in secondary care for management of all of their risk factors. Signs of low testosterone. So on examination, we might see sparse body hair, gynecomastia, low muscle mass. And then you may need to examine their external genitalia or do a PR to assess the prostate, only if that's relevant in their history. Don't necessarily need to do it with every patient. And then one of the tests that they can do in secondary care under urology is a Doppler with an intracavernosal injection. So this will help them assess whether there's a blood flow problem, or it helps them assess as well whether the patient can actually have an erection and the duration and the quality of it. And that again can guide management or potential causes. So the picture on the left is a part of a questionnaire that we can give to patients. They can fill it in, and like I was saying before, it helps us understand what's affecting them the most when they're noticing that their erectile dysfunction problems are affecting them, and it can kind of help guide us on what we can support our patients with and what needs investigating the most. I'll link that in the post-session notes, so you can have a look at the full questionnaire if you want to. It's not very long. I think it's this plus one more side of A4. And it's all on number scales, So it's pretty self-explanatory. Patients can just nip through it quickly, add up the score, and we can kind of get some really, really useful information from that. And then this on the right side is from the NICE guidance. Again, that'll be linked in the post-session notes, but it kind of helps us look at when you've got patients with erectile dysfunction, what is their cardiovascular risk? So our Q risk can help us in one side, and then this can kind of help us think, right, we know that they've got some cardiovascular risk factors. What sort of risk level are we working with here? And the reason that that's really crucial is that if we've got patients with a very, very high cardiovascular risk, we need to safety net them until they're seen in secondary care. Okay, so management of erectile dysfunction goes through all different kinds of specialities. I'm sorry that this slide has gone a bit funny with the text going outside the boxes. It didn't look like that when I made it. Anyway, basically all different medical teams can get involved with supporting patients with erectile dysfunction. So from A&E to GP all the way to mental health. So A&E, some patients can present to A&E with priapism. So if you don't know what that is, it is an unwanted sustained erection. It can be really, really painful and can cause patients lots of problems. Sometimes this can be caused by medications used to treat erectile dysfunction. It needs urgent management. Then urology. So these teams can treat primary erectile dysfunction, pelvic, perineal or genital trauma. They can treat patients with structural abnormalities, or if they've got abnormal testicular exams, they can be referred over to urology for a little bit more support. Cardiology, so for our patients who are intermediate or high cardiovascular risk. So that's the point where what I was saying, we need to safety net them. Sometimes we may have to tell patients that sexual activity may be unsafe for them, and we would advise that they don't partake in any sexual activity until they've been seen by a cardiologist. And they also might not be able to take a PDE5 inhibitor, which is a common treatment. Endocrinology, so if we've got patients with suspected hypogonadism, or if they're considering testosterone supplementation, endocrinology is the place to go for that. And then mental health, so if patients have a mental health cause erectile dysfunction, or for example, if it's caused at least in part by being on an antidepressant, for example, then seeing a mental health professional can help support them with the psychological side of it, but also with medication reconciliation and looking at if there's another option for them, if we can kind of optimize what medication they're on. Okay, so in primary care, there's lots of bits and bobs we can do for erectile dysfunction, because this is normally the first point of contact for a patient who has these symptoms. So lifestyle advice, stop smoking, lose weight if that's applicable to the patient, reduce their alcohol or stop it altogether. Again, that can be applied to patients presenting with all sorts of different symptoms, and it's just generally good lifestyle advice. Cycling, which I didn't actually know until I was preparing for this session. So if they cycle for more than 3 hours a week, ask them to stop cycling for a bit and see if it improves. If we're concerned that their cardiovascular risk is so high that sexual activity might be dangerous, like I said, we'd advise not having any sexual contact until they've had a cardiology assessment. We want to optimize management of any relevant conditions, risk factors, so cholesterol, have we got them on a statin? Are we monitoring that? Hypertension, again, have we got them on antihypertensives? Have we given them a home blood pressure monitor? And then review their medications. Are they on anything that could contribute or cause their erectile dysfunction? So like I was mentioning before with things like antidepressants, can we optimize those medications? Can we provide them some CBT or some extra psychological support if that might be of interest to them? Okay, so for those not at a high cardiovascular risk, you can give them a PDE5 inhibitor. So that's things like sildenafil, that's commonly known as Viagra. That can now be bought over the counter as well, or tadalafil, which is known as Cialis. Usually patients will refer to these by their brand names. I think that's how most people in the community know these drugs. If we are going to prescribe a PDE5 inhibitor for a patient, we need to review it after 6 to 8 weeks to check whether it's working. If it's not working, we could increase the dose or we could try a different drug. And if there's failure to respond with 2 different drugs, the patient would be classed as a non-responder and we might want to go on to more invasive management. Okay, so if oral medication is not effective, other options obviously would not be initiating them in primary care. This would be a specialist. So we could use a vacuum assistance device, which is the picture on the bottom right-hand side. Intracavernous injections, which is the picture on the bottom left. Those do carry a high risk of priapism, like I said, which can be something that needs urgent medical treatment and can be painful. So it's really up to patients, again, what matters the most to them, what their preferred treatment would be. They can have a medicated urethral system. They might need vascular surgery or angioplasty if they've got a vascular cause of their erectile dysfunction, or they can have a prosthesis, which is the most effective option, but obviously, again, one of the most invasive and one that we wouldn't offer as a first line to people. This would be sort of down the line if they're a non-responder to several other treatments. Okay, so that's basically a brief overview of dyspareunia and erectile dysfunction. I know that that's been a lot of information in one go, but I hope it's been reasonably easy to follow. So I've just got 2 SBAs at the end of the session. So I was trying to think how the UKMLA would address these topics, because they are both key topics listed on the UKMLA content map. I obviously haven't sat the UKMLA, but this is how I would assume that they would look at these topics, and again, looking at that holistic management. So if we look at number 1, so you're a foundation doctor working surgery. Your next patient is a 28-year-old female presenting with dyspareunia. She explains she has had deep dyspareunia since the first time she had sex at age 19. She also reports always having had heavy periods with lots of clots and strong cramping. The pain is severe enough that she finds it debilitating and often has to take time off work. She has no other past medical history and has no allergies. She's a non-smoker, works in a desk job, and drinks a glass of wine a week. So given the information we have about this patient so far, which of the following would be the gold standard for diagnosing the likely cause of her dyspareunia? Okay, so A is hysteroscopy, B is FSH and LH blood tests, C is a cervical smear, D is a diagnostic laparoscopy, and E is a vulvovaginal swab and microscopy. So I'll give you sort of 20 or 30 seconds to have a think about it, and then we'll chat about the answer. Okay, so I can't see the chat, so I'll just chat through what the answer is, and thank you if you...
Oh, we don't have any responses so far.
All right, no worries. I can give it a little bit longer, or I can just chat through what the answer is.
Okay, we have D, diagnostic laparoscopy.
Okay, perfect. So yeah, that's the answer that I was going for. So if I'll have a chat through the case, and I'll kind of tell you how I came to conclusion. So basically, this patient's presenting with deep dyspareunia. So if we use our kind of flowchart that we looked at before, that kind of makes us think more of an internal problem. So are we thinking a pelvic problem or an abdominal problem? It's always been there. And she has this key finding of always having had heavy periods with lots of clots and strong cramping, bad enough that she's having to take time off work. So essentially what I was trying to get at with that presentation is endometriosis. So this is a really common presentation that you'll get in GP or in gynecology. And our gold standard, like we mentioned before, for diagnosing endometriosis is a diagnostic laparoscopy. And that basically literally allows the surgeons to see the endometriosis. Again, I think our gynecology team will be covering that in more detail in one of their sessions, so I would have a little look out for that if you're looking for more information. Okay, and our second question is as follows. So you're a foundation doctor working in a sexual health clinic. Your next patient is a 17-year-old male presenting with erectile dysfunction. So he explains that he's struggling to achieve and maintain an erection. He's never had this problem before, and it started when he got into his first serious relationship. His partner's been very understanding, but has encouraged him to come and get some help. So you do an initial set of observations and some blood tests, all which come back normal. The patient has no genital abnormalities that you can see. His BMI is within normal limits. He doesn't drink, smoke, or take any drugs. So given the information that we have so far, which of the following options do you think would be the most appropriate initial management option for this patient? So our options are sildenafil tablets, so Viagra, intracavernous injections, abstinence, psychosexual therapy, or a prosthesis. And I'll just give you a little bit of time to have a think about it.
We've got a couple of responses which say D, psychosexual therapy.
Yep, so that is the answer I was thinking of as well. So I'll talk through for everyone in case you weren't sure. So the reason that I got to this conclusion is, so we're seeing a very, very young patient, first of all. So not that it's impossible for a 17-year-old to have high blood pressure, high cholesterol, type 2 diabetes, but it's less likely. The other clue that we have that this might be a psychosexual problem is he's never had this issue until he got into his first serious relationship. So if, again, like we said before, if he's able to achieve and maintain an erection in private or up until a certain point in life, and then it's related to a relationship, it's one of the things in the back of my mind that I'm going, could this be a psychological cause? The other clues that I had were that his observations and bloods have come back normal. So the observations that we might do would be a weight, a height, a blood pressure, all of which come back normal, and the blood tests, so an HbA1c, a cholesterol, mean that our cardiovascular risk factors, if they're all normal, we've got a very, very low cardiovascular risk. His BMI is within normal limits as well, and he doesn't drink, smoke, or take any drugs. So again, very, very less likely to be a cardiovascular cause. And he's got no genital abnormalities, so unlikely to be an anatomical cause. The other reason it's unlikely to be an anatomical cause is that he hasn't always had this problem. So if he had something like Peyronie's disease or another genital abnormality, it's likely he would always have had this problem. So that kind of led me to think, okay, this is probably a psychosexual problem, in which case our first line for patients with more psychogenic causes of erectile dysfunction would be some psychosexual therapy. Okay, so that's the end of our session for this evening. Thank you all so much for listening and for interacting. I really appreciate it. Hopefully soon we'll have our new website set up, so it's mlamedics.com, and whenever that's set up, these 3 articles will hopefully be available for any of you that would like a little bit more extended reading. When the session's finished, I'll get the recording uploaded to Medal and to YouTube, and there'll be a link somewhere to all of my my resources and some extra patient information leaflets and things like that. If you think you might find those helpful, they're usually good for OSCEs, and also I find patient information leaflets really useful for being able to explain to real patients and OSCE patients in patient-friendly language, because I think we're often taught in textbook language, and while that's really good in some ways, it's not always great when you're trying to explain to someone who doesn't know a lot about medicine. So hopefully you'll find those helpful as well, and yeah, thank you all for coming.
Great, thank you for the session. We've got a few thank you messages, and that it was a really useful session.
Oh, well, thank you all for coming. I'm glad you found it useful.